Hi, folks. This is John Adamson, the Rehab Documentation Guru, and today I've got a special treat in that I have my fellow colleague, former coworker, and good friend Kirat Shah on the line today in this video. Welcome, Kirat.
Thank you for having me here, John.
I just wanted to introduce you, Kirat, because once I introduce you, I think people will understand why I have you on this video. So Kirat Shah has been a therapist for a number of years. He went to Loma Linda University. He is not only a PT, but he is also wound care certified. So he's got his WCC from the National Alliance of Wound Care and Ostomy. He's a certified wound specialist. He is also LANA certified as a lymphedema therapist from Lymphology Associates of North America. But not only is he certified, he's also a certified trainer and has trained lymphedema internationally. So I guess you could probably get the bent of where I'm going with this interview today. He's worked in a number of different settings for the last several years, so pretty much the gamut of what you can do for geriatrics therapy. And he is currently Vice President of Lymphedema and Rehabilitation Consultants based out of Richmond, Virginia. And he's Vice President because he made his wife President, which is probably a good idea anyway, right, Kirat?
That's true.
let the wife run the business.
That's true.
So, Kirat, we're just going to start off going right into the content I wanted to cover today. And can you explain to the audience of this video, because most of us therapists don't generally get into this specialization, what in particular is lymphedema?
So lymphedema is many times mistaken with edema, but there's a subtle difference. Edema is accumulation of fluid. That's it. But lymphedema is accumulation of fluid and protein. And this is normally removed by the lymphatic system in your body. But as there is some kind of a structural damage or medical changes going through, the lymphatic system does not clear it, and we start seeing accumulation of the protein along with the water, which leads to lymphedema.
Excellent. And, of course, the bent of this call is going to partly be discussing how do we get rid of this stuff? And then, of course, related to my videos, how do we document this?
Right.
I wanted to ask you if you have any idea, what is the incidence amongst the elderly, age 65 and older, of lymphedema?
So when we talk about incidence for lymphedema, I don't have the latest numbers to be precise, but as the lymphedema of late has become a primary focus for treatment, as the advances in cancer treatments are increasing. As the survival rate with cancer treatments increasing, the patients who are surviving post-cancer treatments where the lymph nodes have been removed or dissected, or they have received chemo and radiation, which has affected their lymphatic system, that is what is leading to an increasing incidence of lymphedema. Another thing with lymphedema is once a patient goes through, let's say at the age of 30, the patient underwent a radical mastectomy, where all the lymph nodes were removed, and they don't get swelling for maybe, let's say, 10 years or 20 years. That does not mean that their chance of procuring or getting lymphedema is lower. The longer you don't have the lymphedema, the higher your chance of lymphedema appearing in your case may happen. Now, there's a small percentage of people who are anatomically different, not that they have four hands, but they have more lymphatic collectors and different pathways which will reroute the fluid. So they may never have an incidence of lymphedema, but as you say, as the survival of the patients is increasing post-cancer, we are seeing more and more incidents of lymphedema happening.
So basically what we're looking at is a couple different things. Number one, more awareness of the necessity of addressing lymphedema. And then two, we're dealing with more and more medically complex patients that are causing the necessity of lymphedema management.
Right.
Go ahead.
No, go ahead.
Well, I was going to ask you, so I'm not a lymphedema practitioner myself, but I am familiar with what Medicare's regulations are related to this. And one of the words that's thrown about is called decongestive therapy. And Medicare talks about it in its regulations, and it's something that they recognize a therapist being involved in. Can you explain what decongestive therapy is in a nutshell?
So the gold standard for lymphedema treatment, which has yielded really good results so far, has been complete decongestive therapy. Now, complete decongestive therapy, if you look at literature, will be referred to as CDT. And CDT entails four components. So you have your skin care. If you look at patients with lymphedema, their texture, quality, and overall appearance of their skin and the limb is very different from a normal limb. And it's a progressive condition. So the chances of them having fungal infections, cellulitis, it's really high. And that's why skincare is very important. And skincare would be one part of CDT. The second one would be manual lymphatic drainage, which is a gentle massage. We don't like to use the term massage. It's a drainage. Massage means to knead, which is deep, and this is very superficial. Your lymphatic system lives kind of just beneath the skin, so you're manipulating with the superficial skin when you're doing the manual lymphatic drainage. Then comes compression, where you're using different products such as short stretch bandages, Coban, medium stretch bandages, sometimes 3-layer wraps, 4-layer wraps, to bandage the extremity so that it can come back into shape. And with all this, you incorporate exercises to activate and facilitate a muscle pump to help with drainage of the fluid. So all the four components together, they form the basis of CDT.
Excellent. And it's just what you're saying is basically a reminder, and many clinicians know this, why when you have lymphedema, things like TED hose are almost completely ineffective in removing it.
Right. TED
Right.
hose. A TED hose, if you look at the history, they're meant for patients who are bedbound. But as soon as the patient goes into orthostasis or they sit up, the TED hose, the amount of pressure they exert is too low, and they only will do one job, is cause a tourniquet and get your wound care nurse some more wounds to work on.
Right. They're too low where you need it to be higher, and they're too high
Right.
where you need it to be lower, because you're
True.
not opening up the system, so to speak, to drain
Right.
out that stuff.
Right.
Now, wanted to talk to you about the difference between primary and secondary lymphedema, because there is a distinction in how we approach the care with patients related to that.
So primary lymphedema is something that the patient has acquired without any outside intervention, like a surgery or an accident or radiation or chemotherapy. So basically something that the patient was either born with, or their lymphatic system was underdeveloped or poorly developed. And it doesn't necessarily present right at birth. It can present right at birth. It can present in your teenage years, but there is another condition called lymphedema tarda, which can appear in the adolescence or towards the later years. The most common cases are where women, they deliver a child, that's some traumatic event happening, and then they have swelling in their leg, which just doesn't recede.
And that would be a primary
That
lymphedema.
would be a primary, yes.
Okay.
Now, secondary would be where they had a breast cancer surgery, where they removed all the lymph nodes, or they had radiation, they had hysterectomy, post-uterus cancer, or ovarian cancer, where they removed the lymph nodes. Once the lymph nodes are removed, once there's any kind of external damage happening to the lymphatic system, which leads to swelling, it will result in secondary lymphedema. Now, sometimes orthopedic cases can also work into secondary. They may not be directly a secondary lymphedema, but let's say someone undergoes an ankle fusion, and now they're losing the calf pumps, which leads to chronic venous insufficiency, which is another condition, but you would see the purple discoloration around the ankle. The swelling comes on towards the end of the day. You go to bed, the swelling goes away. but over a period of time, it persists for extended period of time, and then it starts going through the phases of lymphedema. That too would be categorized as secondary, but there's a separate term for it, which is called phlebo lymphedema. So lymphedema stemming from vascular conditions. There are other conditions which can also be mistaken for lymphedema. There's a condition called lipedema, where there's abnormal proliferation of fat, and most commonly seen on the lower extremities, but there are also cases of it being seen on the arms and the upper body. So they all can be treated with the same approach of CDT. The goals would be different in each condition, though.
And the treatment approaches, I would imagine, are definitely different.
No.
No, they're not?
They're not. There's subtle differences that the lymphedema therapist would know. And the difference comes only when we talk about the manual lymphatic drainage. Everything else is pretty much standard.
Okay. Well, you mentioned lipedema. I think I need that around my midsection. Maybe we can figure out how to help me with that.
Right. I'm swollen all over too.
Well, I wanted to cover with you the absolute contraindications to lymphedema management, because obviously when you're dealing with medically complex patients, sometimes there's a good reason not to address it.
Right. So remember, whenever you're doing lymphedema treatment, you're basically sending all that fluid back into circulation. When it goes back into the circulation, it's going to overload the heart or overload the kidneys. Now, that being said, if the patient has congestive heart failure where they already have fluid build up around the heart, you don't want to be dumping more fluid on the heart. So congestive heart failure is not an absolute contraindication, but acute incidence of congestive heart failure is an absolute contraindication. So many times when I started practicing initially, and I was just talking about I can treat swelling and I can treat lymphedema, and as the word started going out there, I started getting a lot of patients with congestive heart failure in acute phase. But as a clinician, you want to step back and look at the global picture. The patient's going to have increased shortness of breath. They are going to be very, very, very debilitated, won't be able to walk more than 5 to 10 feet without getting very winded. So, and there's also a medical test called BNP, which can be done to see if they are in the acute phase of congestive heart failure or not. So that would be good information for you to know when to get in and when to get out, treating lymphedema. Most of the lymphedema cases are being treated on an outpatient basis, but there are facilities, not here in Richmond, but there are facilities in California that I've heard of where they treat patients with congestive heart failure in acute phase, and they are monitoring them because they're doing it in-house. The other contraindication would be your renal failure. So if a patient has a complete renal failure, you don't want to be dumping all that fluid on the kidneys, and the kidneys are not functioning. So in that case, you might not be able to do much in terms of CDT. Compression could help some, but CDT or the manual lymphatic drainage wouldn't do you much good. The next one is cellulitis, any acute infection. You don't want to do anything in that condition. Now, when we talk about cellulitis, you can have a bacterial infection or a fungal infection. If you have a bacterial infection, everything needs to be cleared before you go and treat the patient. But if it's a fungal infection, you can start the treatment once the medication has been administered. And there would be, again, some modification to the treatment so that we don't make the fungal spore spread and things like that, that a certified lymphedema therapist would know. The other contraindication would be fairly basic to rehab. Like, we wouldn't do therapy with anyone who has an acute DVT. So you wouldn't do complete decongestive therapy with anyone who has acute DVT. Mm-hmm. Again, there are certain components within the CDT which would be skipped based on different conditions. But when we talk about absolute contraindications, it's an absolute no to do CDT. These four would kind of primarily stick out.
And you bring up so many good points about why it's so important that therapists really know their stuff when it comes to medical complexities, because you're going to be altering a lot of the care approach, even something that we tend to think of as being purely peripheral, manual lymph treatment. Uh,
Mhm.
but there's so many things that could be going on internally, and we've got to pay careful attention to the comorbidities and the complexities of our patient.
Right.
So, and you taught, I've been learning stuff this whole video. Now, Kirat, what are some of the measurements that you take as a lymph management specialist that allow you to objectify where the patient's at and the effectiveness of your treatment?
So circumferential measurement is the easiest because all you need is a tape measure. It's tedious, but it's not super expensive. So different companies take different measurements. Ideally, I like to take measurements every 4 to 8 centimeters. So the way you would start is you would probably pick an area of the hand or the foot that doesn't swell up. So basically, if you take the base of the nail bed of the middle finger or the ring finger or the index finger, and then you start measuring your distance from there, mark those areas and consistently keep measuring this at the same length from those areas. It'll give you a standardized measurement. What you want to be careful about is documenting whether you did it in sitting, supine, standing, and try to maintain that consistency. Um, Same thing with the legs. Now, when it comes to objectifying the measurements, the best way you can do it is take a picture, and picture will tell you 1,000 words. But some companies, they don't like to have pictures because there's no standardized way to have pictures. But in
HIPAA.
lymphedema case, yeah, HIPAA. So if the patient agrees, many times I'll have the patient take a picture for their own record, and that way you can keep seeing how much progress they're making as well. Another thing is when you look at the overall skin texture, they have wounds, they have papillomas, they have warts, they have hyperkeratosis, they have fungus, they have abscess, they have fistulas, they have so many things on one extremity with lymphedema. So photographs would be the best way, but if not, then you would have to sit and write all that down. But to have a standardized measurement, you need to measure them anyways to order garments for the patients when you're getting ready to discharge them. So we use the same measurements that we would use to measure them for the garment. That way, as you're going through with the treatment, you already have the measurements that you need for ordering the garment.
And you bring up such an important point, and that is number one, standardization of how we
Mm-hmm.
test things, because a lot of therapists, going from therapist to therapist and progress note to progress note, sometimes there's a lack of standardization of testing in any functional area, which can cause problems with reporting. And then you brought up another really good point, and that's basically having specific landmarks all the time. And I talk about this in my documentation bootcamp course, how documentation of anatomical references demonstrates skill, and your ability to differentiate the lateral malleolus and 4 centimeters up from that is evidence of a knowledge that not everybody has, and that's really important.
Right.
So what are some of the typical functional tests that you do, Kirat? If you're looking at lymphedema, which I would call an underlying impairment impacting functionality of the patient, what are some standard functional assessments you typically like to use with those patients?
So pain is always a good one. Pain, balance. You can do a Tenetti or a Berg balance, but mainly because they have one part of their body which is so swollen and another one which is normal, their center of gravity is shifted, which is affecting their balance, their ability to walk. Sometimes timed up and go is also a good one for these patients because the gait speed changes as their swelling goes down. We have a very high incidence of phlebo-lymphedema, which is affecting the lower extremities. And these patients, you see a lot of change happening from your lymphedema treatment, and their walking speed improves, um, balance scores change, um, and the pain goes down. A lot of them, they have orthopedic changes happening because of postural change. And that is again to do with that extra weight that was lugged on one side of their body or the leg or the arm, which is affecting their biomechanics in general. And with that, you will also see an overall improvement in their functional transfers and overall mobility. So when you talk about bed mobility, when you talk about gait training, when you talk about transfers, toilet transfers, shower transfers, all those things start improving. And they can all be baseline measurements for your assessments.
Excellent. You actually answered two questions right off the bat, and it's good to point out for the viewers of this video that, like Kirat said, it can be any functional area, and so the edema itself is not necessarily by itself the only thing we're treating. We're treating the function that's problematic because of it, and so I appreciate that. And you touched base on the goals. Goals are going to be related to functional problems as well. Kirat, what are some typical CPT codes that you're billing when you're doing lymphedema management?
Before we go into the CPT codes, John, one more thing about the goals that I wanted to mention is with lymphedema, there's an expectation that it's a lifelong condition. It's not something that you fix and it's done. So the patient needs to be able to self-manage it. So the goal is to train them on the manual lymphatic drainage, for them to be able to do compression, so they can either have a garment or they should be able to self-bandage. So as the treatment goes on, there is a component of patient education involved with this. Once I order the garments for the patient, what I do is I'll have the patient take a video of me putting it on the patient so they can keep doing that. There's also ample of YouTube videos for different products that the patients can go and take a look at. So that's also an excellent learning tool, because sometimes it coming from a different source helps them versus the same clinician over and over again. So my goals would include them being able to don and doff the garment, for them being able to do self-MLD, and also for them being able to know the contraindications and red flags when they pop up, and they probably need to go see a doctor or come and see me. In order to prevent it from exacerbating and going out of place. And one more thing with these patients is you follow up with them every 6 months, because these garments, they have a lifespan of 6 months. So they may have to be reassessed for a garment. Sometimes the garments may last longer, but the manufacturers normally give a warranty of 6 months. Some of them go for a year, some of them 2 years. But depending on whatever product they're using, the clinician would let you know how long you have before the warranty expires. That kind of helps you form a plan of care for the patient.
Excellent. And that kind of, for those viewers that have been to my course, Documentation Bootcamp, where I talk about MICE goals, M-I-C-E, Kirat is touching base on the fact that we transition patients eventually off of our care, where we at first are maybe improving those underlying impairments like edema. We're teaching them to compensate in their lifestyle to manage that. And eventually they've got to take it over, or another caregiver has to take it over. E, environmental adaptation. But there is an element, kind of like what Kirat's mentioning, is the fact that over time, these patients will need to be seen. It's a lifelong management process. And so there is an element of even maintenance therapy in this, whether the patient continues on care or they're just intermittently on care.
Right.
Kirat, do you have anything to add to what I just said, or you want to move on?
No. Yep. We can move on.
All right. Excellent. Excellent answers here. So why is it important for a therapist to consider getting advanced certification in lymph therapy?
Honestly speaking, when I went to school, 4 years undergrad, a year of master's, I didn't get much information on lymphatic management. And I think this was about 10 years ago. So things may have changed. There is a more understanding, or an willingness to understand that there is a lymphatic system. When I was in school, all I was told is lymphatic system is the waste carrier of your body, and there's not much that goes on there. If you have an infection, they swell up. If you have a problem, they swell up, and that's where the doctor finds out. But the advanced lymphatic certification, it opens up a lot of avenues for you. This treatment is not just used for lymphedema. It can be used for any and every orthopedic surgery. What is the most common thing you see after an orthopedic surgery? Swelling. You can treat swelling. It can be used for conditions which are inflammatory in case like rheumatoid arthritis, causes swelling. Osteoarthritis causes swelling. And when I first started doing home health, one of my focuses was I was just doing, when I had my knee replacement patients and hip replacement patients, I would spend my first 2 or 3 sessions just doing manual lymphatic drainage. You don't need to do everything else like compression and skincare, but manual lymphatic drainage. And the results were amazing. Their pain would drop from 9 on 10 to 2 on 10 intra-session, like within the session I start, and in 30 minutes they're at 2 on 10. I could get them to do stairs sooner. I could get them to walk sooner. I could get them to weight bear better. So overall functional mobility improves. Also, think about it this way. You have your skin that has received incision for surgery, and you have your blood capillaries on the bottom, which are providing the nutrients for the healing. Now you have swelling in here, which increases that distance. So as you reduce that distance, that healing transfer speeds up, which helps with the healing a lot faster. And that's why this applies in multiple conditions, and not just lymphedema.
Well, you bring up such an important point that this has carryover to so many different areas of treatment that we as therapists get involved with. Kirat, you are an excellent trainer, and I say that without reservation because I've gotten a chance to teach courses with you. How can viewers of this particular video find out about taking a course from you to get their CLT?
So there are multiple schools that offer lymphedema certification. I teach through one of the schools. It's called Academy of Lymphatic Studies, or acols.com. And you go on their website, sign up for a course, and one of the instructors would be there. All the instructors with the academy and all the other schools, they're really good. They go through a rigorous process of attending the course, which is a 9-day, 135 hours of literal digging down into your lymphatic system. It is a tough course. It's an expensive course, but when you come out on the other side, it is really eye-opening. So I teach through the Academy of Lymphatic Studies, and if any of you out there is looking for a school to look into, acols.com may be a good option.
Excellent. And if a therapist is not well versed in this particular area, but they happen to reside in the greater Richmond area, and they have a patient they think could benefit from your services, how would they go about referring that patient to you?
They can send me, they can give me a call at my office. The phone number is 804-505-4849. And they can send me an email at customerservice@larcpllc.com. And John, if you want, you can post it on your notes under the video. So that should take care of it.
I will do so. That's great. Well, Kirat Shah, PT, let me make sure I get all this. CWS, what's the other one? WCC, CLT-LANA. Did I get them all?
You got them
all. Thank you so much for your time and talent, because what this video is going to do is it's going to help the therapists that view it get paid for what they do. And that's what the Documentation Rehab Guru is all about. So thank you all for watching this video. Please like and subscribe and comment below. And if you have questions for Kirat, I'll make sure he gets them. Again, make sure you get paid for what you do. God bless and have a great day.